Good morning. I'm Elizabeth Fiddleson, for those of you who don't know me. I'm the director of our Women's Mental Health Program and the co-director of our Domestic Violence Initiative in Psychiatry. And we're really excited to have our speaker, Dr. Claudia García-Moreno, join us today. Before I introduce our very esteemed speaker, who truly is an international leader in global health, I would like to say just a few brief words about why we're hosting this particular session in October and why we have hosted a domestic violence related grand rounds for the last several years. As well, as I'm speaking, I'm just going to share one screen with some resources about domestic violence, if that's possible. Let's see if this will work. And then I'll stop sharing for slideshow. Okay, so I wanted to say a few brief words about our local efforts here at the intersection of mental health and domestic violence, with first a few very brief, sobering local statistics before we hear from our speaker about the global perspective, and then hopefully a more hopeful message about how we in psychiatry can make a difference. Just for reference, in 2020, the New York City Police Department responded to 233,000 domestic violence incident reports. Of these reports, 105,000 were intimate partner violent related incidents, and 75,000 were family related. There were 29 intimate partner homicides in 2020 in New York City and 29 family-related homicides in New York City in 2020. And as we all know and have learned, some of us more than others perhaps, that in this pandemic, there is a tremendous amount of underground suffering, and these are likely underreports. However, in 2013, thanks to the generosity of the Chapman-Perlman Foundation, our department was able to forge a partnership with the New York City Mayor's Office to end domestic and gender-based violence in order to start a pilot program providing free psychiatric and psychological care to survivors of intimate partner violence and sex trafficking at the Bronx Family Justice Center. This pilot program was successful because of the amazing team of dedicated clinicians and advocates who made it work, building an important bridge between the siloed worlds of domestic violence advocacy and traditional psychiatric services. The program was picked up and expanded through the Thrive NYC program and New York City Health and Hospitals. It is now a thriving program in all 5 boroughs under the leadership of our former Columbia colleague, Dr. Uju Berry, who's currently on maternity leave now, and John Cancel at New York City Health and Hospitals, with a truly phenomenal interdisciplinary team of mental health colleagues who have been able to continue to care for some of the most vulnerable and traumatized survivors through this pandemic. I continue to learn from them every day. Our team started hosting a domestic violence related ground rounds each October in honor of DV Awareness Month to keep this important topic on our collective radar. As the science continues to demonstrate how life adversity, particularly early life adversity, including exposure at a young age to intimate partner violence, affects our biology and vulnerability to mental illness, I hope the information we are learning together today can inspire our research, education, and clinical care to continue to make the world better for our patients and families. A few individuals to acknowledge here. First is Anna Chapman, our colleague in the Psychoanalytic Institute, whose vision and generosity supported our pilot collaboration. Commissioner Cecile Noel and her team at New York City's Mayor's Office to End Domestic and Gender-Based Violence, Mayor de Blasio and First Lady Chirlane McCray, and our original pilot program team, including Catherine Monk, my co-director, Mayumi Benavides, Rosa Reginkos, and Marina Weiss, as well as Uju Berry, who started when she was just a resident. So please, I'm sharing the screen with some local resources. If you have any patients or questions about domestic violence or intimate partner violence in New York City, these are some of the best resources through the Mayor's Office. as well as very locally through NYP. The DOVE program is truly phenomenal. And there is a domestic violence hotline that everyone is well, you know, if there's a truly emergency, including an immediate threat to safety, is an excellent place to start. So it's truly my honor to get to introduce our grand round speaker today. Dr. Claudia García-Moreno currently heads the unit on addressing vulnerable populations in the Department of Sexual and Reproductive Health and Research of the World Health Organization. She has over 30 years experience in public health and global health policy with a focus on women's health, sexual and reproductive health, and HIV/AIDS. She joined WHO in 1985, following 8 years with Oxfam, and has led WHO's work on gender and women's health and violence against women, including coordinating the multi-country study on women's health and domestic violence, and co-leading the first global and regional estimates on intimate partner violence and sexual violence against women. Under her leadership, WHO has produced numerous guidelines and tools on integrating gender equality and human rights in health, strengthening prevention and health response to violence against women, and the global plan of action to strengthen the role of the health sector in addressing violence, in particular against women and girls and against children, endorsed by the World Health Assembly in 2016. Her team also does research and provides support to countries to address violence against women. She is involved in several initiatives on violence, including as founder and past chair of the Sexual Violence Research Initiative and chair of the Independent Advisory Board of DFID's research initiatives. So please join me in welcoming our amazing speaker. And if you do have questions, please feel free to put it in the Q&A section, and we will have a chance to ask Dr. Garcia-Moreno questions at the end. Thank you so much.
Thank you, Betsy, and good morning, everyone. It's a little bit unnerving not to be able to see anyone and know who's there. I'm still not adapted to that, but I'm going to start sharing my screen and go through my presentation. I will speak for about 40 minutes so that we have ample time for interacting and questions and answers. Can you see it now? Can you see my presentation? Great. So I'm going to spend these 40 minutes going through a global overview of the prevalence and health and other impacts of violence against women, with a focus on intimate partner violence and sexual violence, and also on the relationship between poor mental health, harmful alcohol use, and intimate partner violence. Then I'll talk a little bit about the health response and what the evidence we have around interventions to improve mental health and reduce problematic alcohol use, and tell you about some of the work that we in WHO have been doing and the kinds of tools that we use for working with ministries of health in different parts of the world. And my presentation has a bias towards low and middle income countries, which is where we still, there's a lot of advocacy to do sometimes in terms of bringing attention to the issue, competing with many other, major priorities. And just very briefly to acknowledge my whole team, but particularly in Sardinia, who's behind the prevalence estimates I will be sharing with you shortly, and my colleague Lori Heise from the Bloomberg School of Public Health and Johns Hopkins, who from whom I have borrowed some of the nice illustrations and slides, particularly on mental health and alcohol use. So I want to first acknowledge that violence against anyone and by anyone is harmful and needs to be addressed. There are very specific reasons why we have focused on violence against women and girls, but of course I will also touch on other groups that are particularly at risk. In many societies, and the forms of violence that women and girls experience are still sanctioned and sometimes even allowed by law. There are a couple of countries that still have in their laws the physical chastisement of women by their husbands for certain behaviors, and there is a lot of still lack of recognition, including in the context of health services. So this is why we are focusing on women and girls, but as I say, much of the work that we do is also addressing other vulnerable populations. And also there are many different forms of violence that women are exposed to, and we will really focus on intimate partner violence and sexual violence in this presentation. Partly because they are the most widespread. We know they're endemic. They affect women in all countries, high and low income, and of all cultures and religions, although there are differences that I will also talk about, but also because they are the two for which we have the most evidence. I'll start by sharing some global figures from a report that we just published earlier this year, which is updating the original estimates that we did for the first time in 2013. And we find that still almost 1 in 3 women aged 15 years and older has experienced either physical or sexual intimate partner violence or sexual violence from a non-partner. So this remains an endemic issue that really is pervasive across the world. We haven't seen much change in the last 8 years from our previous estimates, and it affects the lives of many women and adolescent girls throughout the world. When we look specifically at intimate partner violence, sorry, just to clarify that is the combined intimate partner violence and non-partner violence. When we look specifically at intimate partner violence, and we're only looking at physical and sexual, we haven't included psychological, and I can elaborate more on that, but obviously that's also a very important and overlaps also with these other forms. We see that just over a quarter, 27%, if we look at the women aged 15 to 49, or 26% if we look at women over 15, have experienced the physical or sexual intimate partner violence at least once in their lifetime by husband or partner. And if we look at more recent or current violence, which is usually measured as violence in the past 12 months before the survey, we see that it's 13 to 10%. These are global figures, but obviously they hide huge differences, and particularly very big differences in current experience of intimate partner violence or domestic violence between high-income countries and low and middle-income countries. We see, for example, on the left, we see that the countries that are classified as least developed by the Sustainable Development Goals have a past 12 months prevalence of IPV for 22%, Sub-Saharan Africa 20%, Southern Asia 19%, compared to 6% in North America, the US and Canada, Northern Europe 5%, Australia, New Zealand 3%. So there's a very big difference, and this of course has implications for the health response. And these regional figures also hide very, very big variations across countries. And we have countries that have rates that are much higher than the average, much higher than the 27% global average. We have countries, particularly, there seems to be a pattern of countries that have been affected by conflict, like the Democratic Republic of Congo, Afghanistan, Sierra Leone, Liberia, Uganda, those are the ones that come to mind. East Timor, that have rates of, higher than 30%. Afghanistan as high as 46%. So, nearly half of the women have experienced this form of violence. And clearly there's a very big role that cultural norms and attitudes and laws have to play in prevention, but I'll come to that a bit later. Also want to flag that this intimate partner starts early in life. We found that almost 1 in 4 adolescent girls aged 15 to 19-year-old that have been partnered already had experienced physical and or sexual violence from a partner at least once. And 16% of the young women aged 15 to 24 had experienced this within the past 12 months. So I emphasize this because obviously, as we all know, adolescence is a very important time in terms of schooling, establishment of relationships, and many other factors. And this is a very important group that we need to think about and may require, more specific interventions that address their needs. I won't dwell on this one, but just, this is the breakdown of the prevalence by age group. It peaks in the reproductive age. The current, the more recent past 12 months IPV decreases with age as one would expect. But I just do want to caveat that a lot of the data, particularly for low and middle income countries, comes from reproductive health or demographic and health surveys, which are done on women aged 15 to 49. So we have a gap on violence against older women. This is something we're looking to address, to look at how can we better both include older women in surveys, national surveys, but also how do we better capture some of the forms of violence that they experience. And I'm moving now to the prevalence of non-partner sexual violence. The global estimate was of 6% of women have been subjected to non-partner sexual violence at least once in their lifetime since the age of 15. And you will notice that here we have an inverse pattern in terms of the higher rates being reported in the high income countries compared to other regions. We think that this is very much driven by the data that is available and the quality of the data. There are regions of the world where it's still very sensitive or considered very sensitive to ask about this form of violence, so that it's often not included in surveys. So we have, and the surveys tend to focus on the tip of the iceberg. So they ask about many ask about rape and not rape through the use of physical force. So many other forms of sexual abuse that we know women and girls experience, sexual coercion, etc., are not really being captured in our current measures. So this is an area where, in terms of descriptive epi research, there's work to do to refine our measures. Some populations are at higher risk. We know for people with disabilities, there's the evidence shows that they have higher rates of sexual violence. You have, the data on indigenous communities, and we see that in many countries that have indigenous communities, in Canada, Australia, Mexico, Central America, where this has been looked at, that women from indigenous communities have much higher rates of domestic violence and sexual violence. And some of it is also linked to mental health and substance abuse particularly. So a lot of work to be done there, both in terms of better capturing the issues, but also in terms of the responsiveness of our services to the specific needs of these communities, and also for a trans and people of different sexual or of particular gender identity. Also evidence from the US survey that 1 in 2 transgender individuals are sexually abused or assaulted at some point in their lives, often coupled with physical assaults. And also in a systematic review that we did of violence on the basis of sexual orientation or gender identity, we found very big variation, very low quality data in general, but again, high prevalence, particularly for both physical and sexual violence. So we need to be aware and ensure that this is taken into consideration in our service, in our responses. Situations of humanitarian crisis, emergencies, we know also exacerbate different forms of violence. And I won't dwell on this very much, but just these are 2 relatively recent studies from South Sudan and from DRC, and you see that the rates are incredibly high, 68.2% in the Democratic Republic of Congo and 65% of women and girls experiencing physical and sexual violence. And 1/3 of women in South Sudan had reported sexual violence by a non-partner, as did 6% of men. My last comment and my last slide in relation to prevalence is about sexual abuse in childhood. We know that this is an important risk factor for later experience of abuse and perpetration of abuse. Sorry, this data come from the VACS, the Violence Against Children surveys that are being done by the CDC and UNICEF. And you see that the rates are really incredibly high, and we know that this is strongly associated with many health problems, including mental health problems, substance use, as well as later experiences of intimate partner violence and other forms of violence. A systematic review showed that 18% of girls, estimated that 18% of girls and 8% of boys globally have been exposed to sexual abuse in childhood. And from 3 of these VACS surveys, we know that very, very few of those children access services. Around half actually told someone about the violence. A much lower proportion actually sought services, and even fewer received it. So, and this has important implications for mental health and for violence. And just to illustrate that point, this is a slide on what are some of the risk factors for perpetration of intimate partner violence, and it comes from a study in 4 Asian countries, population-based study in 4 Asian countries. And the size of the circles is proportionate to what the data showed. And we see that childhood emotional abuse or neglect, witnessing abuse of the mother, childhood physical abuse. So all of the green ones which are related to exposure are featured very prominently in the men who reported perpetrating. And this is men's self-report of perpetration, as did depression and alcohol abuse. And in the orange are what have been classified as gender inequitable and masculine behaviors. And this is for non-partner violence. And we see similarly that the exposure to abuse in childhood, alcohol abuse prevention all played an important role. So I think, yeah. My slides have gotten stuck. No. Then this comes from a synthesis of evidence also on risk factors. And this is risk factors for experiencing rather than for perpetrating. And the point I wanted to make is that, you know, we usually talk in terms of risk and protective factors for intimate partner violence or sexual violence. We see them across 4 levels: at the individual level, at the interpersonal, at the community, and at the societal. But I wanted to highlight that gender inequality in its different manifestations cuts across all of the levels. We at a societal level, there is an association between prevalence of intimate partner violence and discriminatory laws, whether it be on divorce and child custody or on property ownership or inheritance. And there's a very interesting paper by Lori Heise on these associations, on levels of women's employment and education. And one of the things to highlight is also we need to reflect on how those gender unequal norms, social norms, attitudes also get reflected in our institutions, including the health system. You know, we have a lot of gendered hierarchies within health institutions. We have hierarchies within, you know, between residents and interns, and many power hierarchies where the gender dimensions come into play, and they may also impact on our own attitudes and behaviors and how we respond to our patients, and particularly to patients, to women who or other minority groups who may be experiencing sexual violence or intimate partner violence or other things that are stigmatized. And I think with mental health, there's a double issue of mental health itself being stigmatized, and then, you know, when it's linked to some of these other social problems, or how, you know, things that are labeled and often sort of where victims are blamed, some of our own perceptions may come into play. And I won't, the only thing I wanted to highlight is that both drugs and harmful use of alcohol and mental disorders have also been identified as being important factors. And I'll say a little bit more about that. I don't have my watch, but I'm going to move on to looking at what are some of the impacts of these different forms of violence on health. And these are the range of conditions that have been found to be associated with these different forms of violence. And they include fatal outcomes like homicide or suicide, and a very wide range of non-fatal outcomes. Many and mental health. The ones that have really been most studied in relation to intimate partner violence and sexual violence or depression and post-traumatic stress, but there's association with a lot of these data, or most of it comes from cross-cutting studies. So we cannot say, talk necessarily about temporality, but there are some longitudinal studies. So I'll say a little bit about that. And a lot of the physical health and chronic conditions are mediated through chronic stress as well. And then we see also negative health behaviors. So there are multiple impacts. And as I say, most of that is data from cross-cutting studies, but this comes from our 2013 burden, where we looked at the burden of, at the health burden And this is based on only longitudinal studies where we were able to establish temporality. And that review found that women exposed to intimate partner violence were 2 times more likely to experience depression and almost 2 times more likely to have alcohol use disorders. And we found quite similar findings for non-partner sexual violence. We also found that women who had been exposed to intimate partner violence were 4.5 times more likely to have had a suicide attempt compared to women that had never been exposed to intimate partner violence. And in a separate review that we did, we found that around 38% of all murders of women globally were registered as being committed by their intimate partners, compared to 6% of murders of men. So a lot of distress and harm behind all of these numbers. I'm going to move a little, look more specifically at what do we know about the associations between mental health and intimate partner violence. And there are 3 systematic reviews, including 2 recent ones, a meta-analysis one from 2018, which looked at cohort studies, and one more recent one from 2019 that looked also at perpetration. And these are, I mean, obviously, since there's a lot more information that, and I'll have to share some of the key systematic reviews that exist, but these are sort of in a nutshell, the findings. Women experiencing recent IPV more likely to experience depressive symptoms. Women experiencing depressive symptoms more likely to experience subsequent IPV. And also, and very importantly, a strong association between recent IPV and postpartum depression. And we know that this is, this is already related to stress that can have lifelong impacts on the infant. So I believe that it's a very important time for intervention, and that antenatal care, because we are in a position to see the same woman at least 3 or 4 times, if not more, over the course of several months. I believe that this is an important area to address in our responses. Seems to freeze sometimes. Moving on, another area where the evidence is quite seems to be quite consistent is the link between hazardous drinking and IPV. This association has been documented from studies in many different parts of the world. And drinking, particularly binge drinking, is associated with increases in frequency and severity of the abuse episodes. There's been a lot of debate around, causality versus not causality. But I think that the important thing is that it is associated with frequency and severity. We know that we can reduce and address hazardous drinking through both population level interventions like reductions in availability and taxations and other things, and as well as individual intervention. So it's an area for intervention that can have an important role in prevention. And this association has been confirmed in longitudinal studies and episode level analysis. The evidence on women's drinking and IPV a little bit more mixed. The longitudinal studies do not find an association in either direction between recent IPV and heavy binge drinking by women. But they do find an association with lifetime experience, with the caveat that this can be driven by abuse in childhood. And I mean, there are many challenges which we may get to discuss around the research, both in terms of the choice of outcomes, the measures used, for example, for depression, you have 9 studies and each one uses a different measure. So when you come to doing meta-analysis, it complicates things. So there's a lot of areas for improvement, but and then a lot of studies, for example, of substance abuse or mental health don't include partner violence or sexual violence, and they also don't include child abuse, child maltreatment or neglect. So there's a lot of gaps still in the data. I think this was already mentioned by Betsy, and there are, in addition to the direct health impacts on women, there are also impacts on the health of their children. They range from higher rates of infant mortality, lower rates of childhood immunization. For example, in India, Bangladesh has been documented to I think quite consistent associations with behavior problems, internalizing and externalizing behavioral problems in children, anxiety and depression, attempted suicide, poor school performance, and as we've said earlier, experiencing or perpetrating violence as adults. So again, just to flag, because it is an area for intervention. If you are seeing children with behavioral problems, then think about asking about IPV or other exposures to violence. So just to conclude in this first part, and then I'll move to the health response. Really, there's these forms of violence: intimate partner, domestic violence, sexual violence are endemic and affecting many women and girls. And I was quite shocked to hear your numbers about the number of calls in New York City just in 1 year. We know that populations with multiple forms of discrimination are at higher risk. And we know that survivors of these different forms of violence, childhood sexual abuse, partner violence, have elevated risks for multiple mental health disorders, risk behaviors, and other health problems. So, hence the importance of strengthening the response of the health sector. And, I'm sure for most of you, this is very evident. And I'm assuming, perhaps wrongly, that this is already well addressed in undergraduate curriculum for doctors and nurses and midwives. It certainly was not when I went to medical school. It was never mentioned at all. And most of us start to discover that later. So, but in many places, as I say, we still need to do a lot of advocacy and demonstrating of these associations and the importance of integrating these issues in medical education, in nursing education, etc. in general. Clearly, the health sector is not the only one. We need a coordinated response. We need all sectors to involve, but the health sector has an important role to play, and in many cases, we are not playing it. So one of our roles as WHO is to set standards for health issues and develop guidance based on research on evidence. And so we've tried to do the same for this issue as we would do for any other health condition. I mean, the why health systems, why health providers? I mean, as we've seen, violence is a risk factor for a range of health problems. But also, we know from qualitative research that both women who have experienced abuse and those who haven't think that the health, that a sensitive and non-judgmental, addressing of the issue within health sectors would be beneficial. All women are likely to seek health services at some point in their lives, whether it's for contraception, for abortion or post-abortion care, for antenatal care, for bringing their children to immunization or other things. So and that they, again, from qualitative synthesis, they identify healthcare providers as among those professionals that they would be most likely to trust with a disclosure. And there is also an imperative, a human rights imperative for us to deliver the best possible standard of health care. And yet we know that very often some of these health encounters are missed opportunities. For multiple reasons. And this is, again, one of the things that we would like to address. And yes, it is not like other things. There is no magic pill that we can provide to address or to cure violence, but the evidence shows that a supportive and empathetic response from a healthcare provider can really help women in that pathway to healing and to taking action. Sometimes just understanding that this is not okay and that it is having an impact on their health and of their children can be a motivation to take action. And the other side of the coin of that, if they get a negative, judgmental, blaming response, that is likely to hinder their pathway to healing and to help seeking. It's not a linear process. It's a, 2 steps forward, 1 step back process sometimes. So it's really important to provide an empathetic and caring and effective response. And to, there's a lot of talk now about trauma-informed care. We talk about survivor-centered care because it's better understood in many settings, but it's really about ensuring that we provide an empathetic response that helps women to feel more in control, that where they are part of the decision making, and where we are ensuring privacy and confidentiality and various things. And if we're not able to, then we need to be very clear about what the limitations of confidentiality are. Not doing anything is also not innocuous, right? So we are all committed to the do no harm principle, and it's important that we are also aware and address, be aware that if not identifying or not responding to a disclosure also has consequences. It can lead to women receiving inappropriate care, not providing post-rape care in a timely way could lead to unwanted pregnancies or unsafe abortions. So we need to provide the care, but we also need to do it in a way that doesn't put women at risk. For example, through breaches of confidentiality. So it's important both to have the understanding of the issue, but the dynamics of domestic violence, and to be to respond in a way that does not put women at increased risk of retaliation or obviously a central role is that role of responding and providing health care to women and their children, and that's in a way the core of the health sector, the health service response. But just to remind ourselves that there's also other things that we can do in terms of strengthening coordination with other systems, collecting data that can be used to inform policies and programs, supporting prevention efforts. A lot of the primary prevention lies outside of the health sector, but there are certain interventions like, for example, early childhood development interventions or some parenting interventions that do rely on the health sector, home visitation. And I think that there is a role also for public health in terms of documenting rigorous evaluation, and last but not least, advocating for the recognition of this issue as a public health problem and also a clinical issue, a clinical women's health issue. We usually look at a lot of the studies, a lot of the evaluations of health interventions look to reductions of violence as that principal outcome. And ultimately, of course, that is what we want, and it's an important outcome. But again, just a reminder that there's many other benefits along the way of a good health response, including, what we mentioned about women maybe understanding better what's happening and the impact, being connected to other services, intervening early with children, identifying children who are in distress or who may be experiencing just they're witnessing or experiencing or being exposed to their mother's distress. So a lot of outcomes that are not just about the reduction of violence. And I think I've said this, but just the importance of alcohol, reducing alcohol consumption and providing care. Also, obviously it's part of the response, but it's also it also can play a role in prevention. I'm just going to look at the time. I'm going to run through a couple of slides around the evidence. And again, this is very succinct, but I can share the systematic reviews that underpin our guidelines. One important intervention is, and it's more of a good practice recommendation than an evidence-based one in the traditional sense, around women-centered care or trauma-informed care. And then what we call first-line support, which I will say a little bit more about, but it's an adaptation of what others call psychological first aid. And it's something that any healthcare provider should be able to do. In terms of mental health interventions, there is evidence that supports the use of various different types of psychological interventions, particularly cognitive behavior therapy and EMDR, and there's now a meta-analysis of about 30 RCTs, both in high and in low and middle income countries, showing that brief psychological interventions are beneficial and also can be delivered by lay providers. And I will say a little bit more of that. There is evidence for both psychotherapeutic interventions for children on their own or with their mothers, and psychoeducation interventions for children exposed to IPV. But the systematic review also had a costing, and these are still incredibly expensive for the majority of countries. And it is a very important area for us in terms of research to identify interventions for children that could be delivered at low cost. And then there's some mixed evidence around couples interventions and perpetrator interventions. I think a lot of the perpetrator interventions don't really show much evidence of effectiveness. There is some evidence for motivational interviewing and CBT, but this is an area we didn't include this in our first guidelines, and we will include now in the updating. So we will be looking at those systematic reviews again. And for couples interventions, this has been traditionally something that is not recommended at all in high-income countries. But there's some emerging data from low-income countries, actually, from Rwanda and Nepal, I believe, showing that they used what they call the couples curriculum. So it's not really couple counseling in the traditional sense, but it was a curriculum over 8 weeks, looking at conflict resolution, communication skills, etc. And that showed reductions in intimate partner violence within a relatively short time. And I think this may be related also to the differences in prevalence, where a lot of the countries with very high prevalence, it's very normative. It's kind of something that many people live with and accept because that's the way it is, kind of thing, or you know, that's what marriage, you know, you have to put up with it, kind of thing, versus you know, high income countries where the prevalence is low and probably a lot of the normative you know, acceptability is much less, but where you have more you know, sort of hardcore perpetrators, for want of a better word, or controlling, coercive controlling type of partner. So I think it's important when we're looking at both couples interventions and perpetrator interventions to understand much also more about the types of perpetrators and the links with mental health and other areas. So, you know, what we do, as I mentioned, is that we try to support ministries of health, particularly in low and middle income countries. And so we developed these guidelines in 2013 through systematic reviews of evidence, grading of evidence, and then an interdisciplinary, regionally diverse group that came up with some recommendations, but they're now old, and we will update them and include also some of the areas that were not included in that first version. And then we developed a couple of very practical implementation manuals that are very simple, you know, how to with you know, exercises and job aids. And the clinical handbook is targeted at providers, clinical care providers, but we realized when we were rolling it out that this wasn't enough, that if the system is not supporting them, you know, they were sometimes very handicapped, even if they were well trained in wanting to do more. So we also developed this manual for health managers, which is looking more at the health system, you know, the infrastructure. If you don't have a private space where you can talk to women without everybody else hearing, well, that's kind of a non-starter. So, you know, you need to look at everything, the infrastructure, the training, the having a protocol in place, you know, establishing a referral network. So all the systemic pieces also, as well as the training of individual providers. In the clinical handbook, we do have a strong emphasis on mental health and also on the psychological first line support. We have translated this into a mnemonic: listening, inquiring about needs, validating, enhancing safety and support. So LIVES, which has worked very well and translated into several languages, just as a way for providers to remember. But in particular, the first three, the listening to women in an empathetic way and without judging, and everything from how your posture, your body posture, how you look, the questions you ask, etc. And then inquiring about the needs, and then validating, you know, the validation, you know, you're not crazy, you're not, you know, it doesn't happen only to you, all of those things, and you're acknowledging what's happening. And this may be very evident to all of you, but we still see that there's a really big need. And when we do trainings, it's very interesting to see how challenging this is at the beginning, and how over time, as people, as providers get to practice it more and more, they get more confident with it. We also emphasize basic psychosocial support, you know, from helping women identify their strengths or positive coping mechanisms, to stress reduction exercises, and to, you know, assessing for more severe mental health disorders, risk of harm and imminent suicide, you know, what to do, when to refer. Recognizing that in many of the settings where we are talking about, there is very little in the way of mental health care sometimes, and there is a strong emphasis on the part of WHO to really, of course, strengthen the specialist care where it exists, but also to ensure that primary healthcare providers are better equipped and skilled to provide mental health care. This I've already mentioned, and just a lot of these brief psychosocial interventions, brief psychological interventions, and WHO has been testing several of them, share common strategies, A lot of them are based on CBT skills, motivational interviewing, stress management. They tend to be focused on one single outcome, and obviously, ideally, we are looking also for more transdiagnostic interventions. These are just two to mention. The one is called Problem Management Plus, and it's really a very CBT intervention, but it's delivered by trained lay providers. They do require supervision, and they do require some intensive training with practice and etc. But it has been shown to reduce distress and an impact on depression. And in the Kenya study, they did specifically look at its effectiveness in women that had experienced IPV. And there's another one, it's called Self-Help Plus. They always come up with these trendy names. Self-Help Plus, which is based on acceptance and commitment therapy, and very simple. It's basically some audio tapes and a very, it's not quite like cartoons, but yeah, it's an illustrated booklet. And when we tested that in South Sudanese refugees in Uganda, with very big, with a lot of trauma, a lot of traumatic experiences, including sexual violence, and it showed reductions in distress and depression. And this CETA transdiagnostic is also been shown to be effective in Zambia in reducing IPV to the point where the DSMB actually stopped the study because the benefits were so strong, and it is a family-based trauma from CBT intervention with a focus on it had a specific component to addressing alcohol, and it had I can't remember what exact percentage, but it had a very big reduction on current IPV. I think I'm going to stop there because I'm seeing that I'm out of time, but I think I've said, I'm just going to jump to the conclusions. Just to really recap on some of the things that I've said, that exposure to IPV is associated with mental health problems, and at the same time, mental health problems. Those with mental health problems that are at greater risk of exposure to IPV. So we need to address both. I mean, obviously, with reducing IPV, and we can talk about prevention a bit more in the questions and answers, is likely to have an impact on mental health, but also intervening early and addressing mental health may have an impact on reducing IPV. So we need to enter it from both angles. Similarly, reductions in alcohol may contribute to reductions in IPV, and particularly IPV severity. And obviously this needs measures both at the population level and at the individual level in terms of the brief interventions for reducing harmful drinking. I mentioned already the importance of addressing the perinatal period. We need to strengthen the overall availability and access to and quality of mental health services. We need to strengthen the skills around identification of and response to IPV in mental health and for mental health providers. And the World Psychiatric Association has a not very well advertised and not very easy to locate, but I can share the link, curriculum that looks at different forms of violence, not just against women, but with a focus on women, gender and sexual minorities, and also looking at different mental health diagnosis, case studies, vignettes, and that you might find that interesting. in integrating IPV. I mean, in general, WHO doesn't recommend universal screening because of many issues, which I won't go into. It's a very contested issue, but I think, we do identify both mental health services and antenatal care services as two instances where, if there are things in place like a protocol, like trained providers, et cetera, would lend themselves to asking in a more systematic way about experiences of violence, including intimate partner violence. And then children and adolescents, I think we really need to start early to prevent some of the later impacts of violence. So again, thinking about this when you're responding to children and adolescents with emotional behavioral problems. And yeah, I think we all need to engage with this issue and you know, put it up there on the agenda, because it really affects the lives of many, and it causes a lot of harm and suffering. So thank you, and I look forward to the next half hour of discussion and Q&A. As I say, it's very distressing not being able to see who is in the audience. I have no idea, but
I'll be your audience. We can have a
conversation,
and I'll help filter some of the questions. Dr. Garcia-Moreno, thank you so much for this amazing talk, and I personally appreciated your obviously the global perspective, the clear discussion about the prevalence and some of the reasons for what we're seeing in differences in prevalence between countries, but also different populations, as well as how you brought it down to sort of the individual healthcare provider level. So we have a question, and it was sort of one of my questions too, and perhaps the obvious one in this year. What is your perspective on the impact of this pandemic on the issue of intimate partner violence and domestic violence globally, violence against women and girls in particular?
Sorry, I'm not sure.
What's the impact of the pandemic of COVID?
Yeah, I knew that I was forgetting. I knew that I was forgetting something. I was just thinking I didn't mention COVID at all. Well, I think we know that COVID has affected both intimate partner violence rates in many places, and also mental health in, you know, and so I think we have you know, all these additive effects, and you know, the mental health of young people and adolescents is coming up more and more. You know, one of the debates in terms of the impact on population prevalence, we don't know yet, because we need to start, now that lockdowns are hopefully over. We need to look at that, and we need to look at we are doing some research to look at both the impact in terms of the impacts in services, not just for violence, but, you know, sexual and reproductive health services more generally, and also that even in some cases, what we are hearing is that the prevalence maybe hasn't changed, but the severity, the frequency of the domestic abuse, you know, in some cases got worse. It's hard to put a global picture, because, for example, we all read and heard about the increases in calls to helplines and etc. in some countries, and in other countries we're hearing the opposite. In Nepal, for example, at the beginning of the lockdown, they have one-stop centers, and they went down to zero patient. I mean, like, no one was coming to seek services, and you know, they then launched a campaign to emphasize, and then, you know, in some countries they negotiated that women in these circumstances could break the lockdown rules, et cetera, et cetera. So it took a while, I think, for things to catch up. And there are a couple of systematic reviews that have come out recently. And yes, I think there definitely seems to be evidence that it increased in some settings, and that it may have changed in terms of just the nature of the abuse.
Yeah, it's so interesting because it seems like it's likely to be this very mixed picture, right? That intersects with a lot of the issues around equity and access, as well as the length of time this pandemic might continue, which on a global scale is going to be impacted by vaccine equity, for example.
Yeah. And I think the issue of inequalities, I think if anything, we were having a discussion this morning in our team, I mean, that, yeah, if anything, COVID has exacerbated all these inequalities. And so we really need to look at things with that lens and really keep, be very attentive to which of the groups are being affected the most and which are maybe falling off the radar just because they can't access services. So I think that there is definitely a lot of work to be done. And I think the other issue, I think I was on a panel where older people were talking about the impact of isolation on older people, and there was a very vocal woman who said, like, you want us to not die from COVID, but we're dying from loneliness. And it was very striking to me that the mental health effects both on young people, on older people, on people, loss of livelihoods, loss of employment. I mean, all of those stressors that we know have an impact on both domestic violence and on mental health are really important and very prominent with the COVID epidemic.
Yeah, there's a quote that we cite often. I can't remember who said it, but it was, basically the psychological impact or psychological footprint of the pandemic will eventually be far greater than the actual disease itself. And that seems to be likely, and certainly similar to what we're seeing in New York City, where it's quite a mixed picture, even with access, right? Where there are some groups who are actually better able to access services because they're remote. They access, they don't have to show up. There's a little bit more access that way. And then other groups who are undoubtedly falling off the radar and don't have privacy, haven't been able to, or have been stuck and isolated, which of course is toxic, both for mental health and in violent families. So thank you so much for that perspective. We have another question by William Tucker asking, could you say more about the motivations of perpetrators of sexual and physical violence based on your understanding and your work?
This is a challenging question, but I think from the study, the men surveys that were done in 4 countries, and also another survey that I'm not going to remember what it stands for. It's called Images but it's surveys of men in different countries, asking them about their beliefs around gender, household work, and all these kind of things, trying to get measures of gender norms and masculinities. And I think the issue of sexual entitlement comes out very strong. I mean, it's still, a very prominent part of our cultures, our organizations, our institutions. And, if you remember those circles, obviously the experience of abuse in childhood seems to be an important factor that is impacting the behavior of some of the men. Then there's like a strong bit around entitlement, gender beliefs, what they call hypermasculine behaviors, having many women, drinking, all of those things. And then there is a component of the mental health, particularly around substance use. And I didn't refer to that literature, but there is some association also between mental health, substance use, and perpetration. And I think one of the challenges is that on the one hand, there's the stigma issue, but there's also, not all men who abuse have mental health disorder. And so there's, I think people are cautious about how to portray this. And then there's the big, I don't know, the whole personality disorders box and what all that means, but there certainly seems to be a component of that among a particular type of perpetrators. I personally think that we need to understand much better perpetration and type of perpetrators, because I do think that you have some particularly on the coercive control, what some people have called patriarchal terrorism end of the spectrum, versus the men who just do it because it's my right, or, this is how it is, men have to impose themselves on their wives or else, they'll get trampled over, or, all these kind of beliefs that you can address eventually.
And sort of low frustration tolerance and normalization of violence as communication.
Yeah. And I didn't get into the prevention framework, but we have a prevention framework where we've identified 7 broad strategies, and we've categorized the existing evidence of interventions under those. What is promising, what is, and there are. So it's respect. So there's a relationship skills strengthening, because there is a lot of also partner violence, domestic violence that happens because people don't know how to manage conflict, because communication skills, etc. So there's a component there. There's empowerment of women, economic and social and psychological empowerment, including education, access to employment, closing the wage gap, etc. Then there's services, and we've talked a little bit about that, how addressing mental health and substance use issues early and addressing violence in the context of those services could work better for prevention if it was done more systematically. And so services, RES, the P is for poverty reduction. There is a strong association, I think, more and more, both in high income countries and in poor countries with poverty and just all of the deprivation that is linked to that. Then there's the issue of environment. So, schools in many contexts are unsafe for multiple reasons, bullying, sexual harassment by teachers, all kinds of things. Workplaces the same, public spaces. So, ensuring more safety in different environments. And then there's the T is for transforming attitudes, behaviors, and norms particularly around gender and the acceptability of the violence, because both sexual violence and partner violence, domestic violence are seen still sadly as acceptable. And I think, and there's the whole video games and, media representations of masculinity and how that contributes. I think it's a huge.
Yeah, that's a lot to tackle. For those who are interested, New York City has some interesting things in terms of prevention. There's a healthy relationships curriculum that's rolled out in the public school system. There's also a very interesting pilot that's run in collaboration with the Safe Horizons in Staten Island in families affected by intimate partner violence who are co-parenting, sort of a family-based intervention working on family communication and co-parenting for both the person with resources for both the person causing harm and the identified victims in the service for children, which is really interesting. And a lot of the sort of, I think some of the, maybe the perpetrator interventions you mentioned in your slide about the evidence base for perpetrator interventions is very poor. I think a lot of those were like mandated anger management programs coming out of incarceration, for example, that are very sort of shame-based rather than really more trauma-informed. But of course, resources for perpetrators is also difficult when there's not enough resources for survivors as well.
Yeah.
We have a few other interesting questions. One along a similar line to some of the things we've been just talking about by one of our trainees. Can you speak to what this all means for communities of color in high-income countries who are likely already experiencing structural racism and racial discrimination, which often precludes or stops their help seeking?
Yeah, I mean, I think that as we know that this is a major risk factor because I had a reflection which in the end I didn't use that slide, but you know, like I think that there is a lot of stigma attached to, you know, some of these communities already. Then there is the stigma of mental health, and there is the stigma of violence and the shame and the blame and etc. So I think that the implications are that we know that these communities are usually at higher risk, and that this needs, but you know, we need to focus on prevention, and as you say, not on a prevention approach that is blaming or that is you know, but really on, you know, what are the kinds of services. And I think the other thing that I didn't mention is the importance of engaging with survivors themselves or with communities themselves. I mean, so often we had a very interesting experience in Australia with you know, visiting Aboriginal communities, where we were there to talk about intimate partner violence or domestic violence because the rates were, you know, double what they were for other groups. That, you know, and in some way, when we that was the least of their issues. You know, it was like for the women, they were much more concerned with the drug abuse of their kids or the incarceration of their kids. And, you know, the abuse was almost like, you know, well, it has to do with discrimination, unemployment, all the other things that were affecting their husbands or partners. So I think we need to think of this not as an isolated kind of issue on its own, but really, you know, in the context of where it's happening, of the people that are affected, and really come up with prevention strategies that are constructed with those affected, you know, because we just, I mean, the evidence is great, but it's what it is. It's limited, you know, it's one small study here, one more small randomized control trial here, but at the end of the day, we can take those elements and work with communities to design you know, prevention interventions that are going to be responsive to all of the different issues, including the historical traumas that are there. No, it is challenging. I mean, I don't think there's a solution that is easy, but I think you know, working with the communities themselves and engaging them in the design of programs can at least address some of the challenges.
Yeah, I really love that prevention perspective, in part because, you know, domestic violence services in our country has really been intertwined with law enforcement responses, which, as you know, I think there's growing awareness of how problematic that is. So thank you for that thoughtful response.
I always tell people, you know, I come from Mexico. The last place I would go to for anything is the police, you know. And so, I mean, that is the reality. And we know that particularly with domestic violence, less so with sexual violence by non-partners, but I mean, women don't want necessarily their partners to be incarcerated. No. Sometimes they do just for, you know, so that they change, but it's like there have to be other solutions that are not the criminal justice system. And at the same time, it's very important to have a clear message from the criminal justice system that certain things are not tolerated, because we see the opposite with sexual violence, right? That there's total impunity, hardly any convictions related to sexual crimes. And this is global, even in countries with very good laws and legal systems. And so, we have to find a good balance there. But I certainly think prevention, there's a lot of room to do more and better on prevention.
Right. We have another question about screening, particularly in reproductive healthcare settings. So this question is from Aisha King. Do you think there should be routine sexual trauma or IPV screening in reproductive healthcare settings? I'm additionally interested in ideas of consent with regard to physical touching by medical healthcare professionals, for example, breast exams, routine pap smears, and how that is perceived by women who have experienced sexual violence. So this gets to that question, I think, of that controversial question about screening, right?
Yeah.
And the role of the healthcare setting in identifying.
Yeah, I mean, I think that, so when we did the guidelines, this was the only, I have to say that this was the only recommendation which was not by consensus. But the review of the evidence shows that screening increases the identification, but there wasn't any studies at the time that showed that it actually had changed the outcomes. Although some people would argue that, well, it is the beginning of the process, and if you don't ask, then how are you going to connect those women to other services, etc. An important so there were multiple reasons, and they're spelled out in the guideline. There is a remark that spells out why people thought it was not useful and what the people that thought it was useful, why. In the context of prevalence rates of 30-40%, there was a concern that, if providers start asking every woman and 50% of your patients are saying, yes, I'm in an abusive relationship, and particularly in contexts where you don't have any referral services, where you don't have any specialized service, that would be totally paralyzing, disempowering, and not lead to anything. And if anything, lead to a lot of frustration for both the providers and the women. So those were the rationale. We will revisit that question in that systematic review when we update the guidelines. But I think at the same time, we did identify that some settings, and the two that were clearly identified, I think there was a third one, but I can't remember. I think it was HIV testing, that there were some settings that might lend themselves if you had certain things in place. And we call, minimum requirements that you have a trained provider, because a lot of the screening programs, unfortunately, focus on teaching people how to ask, but not on what happens after you ask,
right.
Or ask and refer. But, many women don't want to be referred. If I'm disclosing to you as my, GP or my primary health provider, I don't want you to then tell me that go somewhere else for, so we had like minimum requirements that the people be trained as a minimum on providing first line support, that a protocol exists so that there are, the pathway for referrals, etc., are there. That you are able to provide privacy and confidentiality, and I can't remember what else. So if you meet those conditions, then I think you could, and particularly in settings where we know that there is a likelihood that the prevalence is high. We did a study on in antenatal care in South Africa in 3 public antenatal care clinics. And the prevalence of past 12 months physical or sexual was 27%. So more than a quarter of the women attending antenatal care are in abusive situations right now. Mm-hmm. So clearly in that context, asking routinely, if you are able to then do something about it, which is the important sort of corollary. Right. And not just focus on asking and learning how to ask and asking in a nice way. It's really about what happens after you ask, and that's, I think, what has not always been very well established in screening programs.
Right, right. Yeah, that's so important. Screening alone isn't necessarily do anything. You need the resources available. And I think there was a qualitative survey of IPV survivors in obstetric care who sort of identified they wanted their obstetric providers to ask them, and they appreciated that. They didn't necessarily all feel like they would disclose. They wanted resources that didn't require disclosure, and they also didn't want disclosure to lead to an expectation that they weren't necessarily ready to leave a relationship. So I think all of that speaks to the training aspect, that the people asking the question, you need to be trained to know what to do with the responses. So wow, this half hour went very quickly. I will just ask my last question to you, thinking about our institution is in academic psychiatry. We are a research and education institution. What would be, if you had an ideal research question that, speaking to the many trainees who are watching here, what do you think our trainees who are going to be future researchers in mental health, what do we need more research on? What would you encourage them to, what questions would you encourage them to ask?
That's a difficult question to answer off the top of my head.
Sorry, I'm putting you on the spot. Your wish list, wish list for the kinds of things you need to know.
I think we need to understand more what are outcomes of success for women, that would be one issue, because we define success as we understand it, right, as providers or from a more distant point of view. And I have the same feeling about safety, because there's a lot of emphasis in the interventions for IPV on safety planning. And again, that may have to do very much with the type of perpetrator you're with. But what safety could mean very different things. And I'm thinking particularly in low and middle income countries that, we often take what has been developed for safety planning in high income countries. And it's like, do you have your bag ready and do you have your documents, etc. And, we don't really know what safety means in many contexts. So I think that's one issue. So understanding better the perspectives of survivors in terms of what are their expectations from the health service. And there is a systematic review that just came out from colleagues in Australia, where the conclusion is that lives should be complemented with what they called care. And I'm not going to remember what everything stands for. Choice and control was the C. I can't remember the other two, but the last one, the E, was for emotional support. So, I think in some of the qualitative research, one of the things that women say they value the most is the communication, continuity of care, not being able to see the same provider rather than being sent to a different one each time they come, those kind of things. So I think we need to get a better grasp of that. I think the other issue is there's been a lot of emphasis on depression and anxiety, PTSD, but not much research on some of the other mental health conditions. Particularly, I'm thinking eating disorders, sleeping disorders. And so I think it would be good to broaden the range of issues that we're looking at. And then I would love it if there could be more consistency in mental health measurement, because you look at the studies and they're all measuring slightly different things. And there is no, this is something I keep telling my colleagues also in the mental health department. Like, can you come up with a short instrument that could, because, it would help a lot to further our knowledge faster if we were all more consistent in what we're measuring. so I think coming up with short instruments for different conditions that could, which is a little bit what we've done for violence, is to say, okay, here are the 10 questions that we think get you a reasonable disclosure. So having the same for mental health would be really helpful. And then I think the other issue which is challenging is that there's very little longitudinal data. And we know that trauma is cumulative, like there are cumulative and effects, and that, so it would be, it would be really valuable to understand more about the trajectory of abuse, and even from pregnancy, because as we said, pregnancy is where it starts, and if that baby is already born, with one of its hemispheres depressed, and and with cognitive issues or developmental issues or behavior, like, it's how do we put it all together so that we can intervene early, and then if we couldn't intervene during pregnancy, then what next, so that I think it would be very useful to have more longitudinal studies.
That's a wonderful, comprehensive answer.
And last but not least, sorry, the groups, the marginalized groups, because, like we did this systematic review on violence on the basis of sexual orientation and gender identity, as we called it. And again, very, very little data, and the data is all over the place because people use different denominations and are looking, there's no consistency in how people are looking at the different groups. And so it's very hard to put together and to say, okay, here's kind of the global evidence in the way that we've done for some of the others. So I think important to look at disabled people with disabilities, people, indigenous communities, as we've said, understand better their needs. So yeah, lots of research guys.
Yeah, great. Well, once again, thank you so much, Dr. Garcia-Moreno. I know you're incredibly busy and your time is so valuable, and I'm so appreciative that you spent the time with us and talked about this important intersection of mental health and domestic violence from your global perspective. And you can see so many people stayed on to watch past the time, so that's a good marker.
Thank you for having me, and congratulations on having this initiative, domestic violence initiative. That's great. Thank you.
Thank you so much. Thanks everyone for staying. The recording will be available. It's in the link is in the chat. And any other questions you have for me to pass on at some point, I'm happy to answer any questions. Share some of the resources that Dr. Garcia-Moreno, wonderful resources she put in her slides as well. So thank you once again.
Thank you. Take care. Bye.
You too.